Hello, and thank you for having me. I'm Victoria Surma. I'm a pediatric cardiac intensivist here at Johns Hopkins. I'm also the Associate Medical Director of the Pediatric ECMO program and an active member of the Pediatric Cardiac Intensive Care Society, PCICS, whose annual meeting was held this year in Austin, Texas. I had the privilege to moderate one of the most highly attended sessions of the meeting, titled Milrinone, Friend or Foe, along with the current president of PCICS, Dr. Lillian Su from Phoenix Children's. Milrinone is one of the most ubiquitously used medications in pediatric cardiac patients. Preliminary results from an ongoing study from the Pediatric Cardiac Critical Care Consortium shows that over half of institutions use Milrinone in 80 to 90% of all patients. However, there's a glaring lack of evidence to support that such widespread use actually improves patient outcomes. In this session, Dr. John Kerr from Boston Children's and Dr. Eric McClellan from Dornbecker Children's challenged the audience to reflect on our practice with the goal of improving patient-specific care. Milrinone is a phosphodiesterase 3 inhibitor, blocking cyclic AMP degradation in cardiac myocytes and vascular smooth muscle. The teaching has been that this allows for improved cardiac contractility, or inotropy, relaxation, or lusitropy, and vasodilation of both the systemic and pulmonary vascular beds on both the arterial and venous sides. Each of these effects has been studied in animal models, but the relative effectiveness of each of these mechanisms is difficult to assess in human patients. Additionally, an inherent challenge in the use of Milrinone is its long half-life, particularly in neonates, making it impossible to titrate as we do with virtually all of our other medications in the ICU. Pediatric cardiac intensive care focuses on tissue oxygen delivery in the setting of varying types and degrees of cardiac dysfunction and differing vascular states. It is the job of the intensivist to assess where each patient falls on those spectra and thus identify the primary physiologic cause or causes of low cardiac output and subsequent impaired oxygen delivery. The inotropic and lusitropic effects of Milrinone may differ depending on the health or preoperative state of the myocardium, but vasodilation is clinically apparent in most patients. We discussed two interesting cases. First, a teenager with Duchenne muscular dystrophy with restrictive cardiomyopathy and respiratory distress. Second, a neonate after tetralogy of Fallot repair on Milrinone with hypotension and high central venous pressure causing atrial level shunting and resulting in systemic oxygen desaturation. Dr. Kerr argued that Milrinone should not be used indiscriminately in all patients, as it often is, based on several physiologic principles, primarily that of venous capacitance. According to this physiologic principle, blood fills the compliant veins as unstressed volume until it approaches the natural capacity of the vessels and becomes stressed volume, able to achieve a driving pressure that will contribute to ventricular preload. Agents that cause venodilation will therefore increase venous capacitance and shift blood from a state of stressed volume to unstressed volume. This is particularly relevant to neonates after repair of tetralogy of Fallot, who are often treated with Milrinone for its lusitropic effect. Dr. Kerr argued that the more clinically relevant effect of Milrinone in that case would be venodilation in a patient who's preload dependent, resulting in worse cardiac output and requiring additional volume resuscitation to maintain appropriate hemodynamics. In the case of the restrictive cardiomyopathy, however, this venodilation would likely improve the patient's symptomatic atrial hypertension, shifting volume away from the high-pressure atria and sequestering it as unstressed volume until diuresis can provide the needed resolution of excess intravascular volume. Thus, Milrinone may be beneficial. Dr. McClellan's primary argument was that Milrinone can quite often be beneficial in the right patients, with the most prominent benefit being afterload reduction, paired with potentially modest improvement in inotropy and lusitropy, improving oxygen delivery. In the case of the patient with repaired tetralogy of Fallot, Dr. McClellan argued that Milrinone provides directed support for a recovering right ventricle by improving ventricular relaxation, minimizing ventricular afterload, and promoting forward flow. He suggested that this benefit outweighed the potential need for small amounts of additional volume resuscitation and vasoconstricting medications required to treat hypotension. Unlike the patient with tetralogy of Fallot, whose restrictive ventricular physiology is the result of hypertrophy of healthy myocytes, which are likely to respond favorably to the lusitropic effects of Milrinone, Dr. McClellan suggested that the diseased myocytes of the patient with DMD are unlikely to respond to Milrinone with improvement in ventricular relaxation. Furthermore, this patient exists in a high SVR state, and the likely result of Milrinone would be a potentially detrimental reduction in blood pressure. The debate was engaging and informative with a captive audience. In the end, we came to a truce on several points. First, that milrinone dilates veins, thus reducing stressed volume, which has potential benefit for symptomatic atrial hypertension, but may also cause hypotension in volume-depleted or preload-dependent states. Milrinone also dilates arteries, reducing arterial elastance and increasing stroke volume for a given contractility. Additionally, milrinone may exert an inotropic effect independent of changes in afterload. And lastly, but most importantly, we concluded that new, well-designed studies are needed in order to better guide the use of milrinone across a variety of changing physiologies in pediatric cardiac patients. Thank you to my clinical and research mentors at Johns Hopkins, to PCICS for this valuable opportunity, and to Doctors Sue, Kerr, and McClellan for their collaboration. If you would like to view more information and resources from our session, use the following QR code. Thank you.